Good morning, everyone, and welcome to our first in a series of webinars on palliative care for D-SNP members. I'm Jennifer Moore-Ballantyne, CEO of the Coalition for Compassionate Care of California. For those of you who are not familiar with us, we are a nonprofit dedicated to improving the experience of serious illness for all Californians, and we work closely with the California Healthcare Foundation and DHCS on a number of projects, including this one, and we've been very closely aligned with them in the rollout of SB 1004 over the past however many years. So we're delighted to welcome you this morning to this webinar, and I will turn it over now to Kathleen Kerr.
Thanks, Jennifer, and hello, everyone. Thanks for joining for our first in a three-part series of webinars about palliative care for D-SNP members. Next slide, please. So a little bit about the webinar series, and I'm Kathleen Kerr. I'm a healthcare consultant, and I'm assisting the coalition with this webinar series. The goal for the series is to really make sure that all of you, the plans, understand the palliative care policy, and we'll have Anastasia go over that in some detail in a little bit. We also want to keep up with supporting networking and peer-to-peer learning. I know that you're doing a lot of that already, but we want to join in that effort, and also have an opportunity to introduce you to tools and resources and lessons learned from implementing Medi-Cal palliative care, which is pretty similar to the palliative care that you're going to be implementing for your D-SNP plans. Please do use the chat feature for your questions and comments, and we encourage those throughout. There's potentially more people than it's comfortable to have interacting verbally. So we're going to rely on the chat feature. My colleague, Lauren Poger, will be monitoring the chat. So go ahead and enter your questions there, and we'll address them throughout the webinar. Next slide, please. In terms of the series content, this topic, implementing a palliative care program within a health plan, it's a big topic. And back when we were working on this for the Medi-Cal managed care plans, there was something like 20 hours of technical assistance that was offered prior to implementation, a lot of other activities through the years. So we could easily spend hours and hours and hours and days going over this. So in the interest of trying to be efficient, we've narrowed the topics down into these three categories, and we're going to try to stay in these lanes fairly closely, just to make sure we have a chance to get through these important points. So today's webinar is going to go over policy, population, so eligibility criteria, services, what's being delivered to these seriously ill people, and then a little bit about palliative care providers. On August 18th, we'll have the second webinar. That one will focus on program administration. So what are the structures and processes that you want to have in place within the plan to promote success of your palliative care program? We'll talk about payment model, and we'll talk about quality monitoring. And then we'll have a third webinar in the middle of September. That one will focus on promoting referrals, promoting enrollments, and promoting awareness of palliative care, three really important factors that will contribute to the success of your program. So as was the case for this webinar, please share the invite with anybody at your plan who has an interest in these topics. Next slide, please. For today's webinar, what we're going to be covering is a brief introduction to palliative care. So there's a lot of different understandings of what palliative care is. We also know that there's folks on this call who are just absolutely expert in palliative care, have been focused on this for many years. There's others for whom palliative care might be very new. So we're going to go over some of the basics. Anastasia Dotson is going to walk us through the DHCS palliative care policy to make sure everybody's clear on that. Then we'll share some information about the Medi-Cal managed care plans experience operationalizing palliative care for their Medi-Cal members. And then we'll have a case study where Dr. Mercy Kagoda from Inland Empire Health Plan will talk about their experiences offering palliative care to their members. We'll go over some recommendations and some resources. So the webinar slides and a brief summary of key points and a link to the webinar recording will all be distributed to everybody who registered. So no need to take notes furiously. You'll have a easy access to this information. And the information will be collated on a page on the Coalition for Compassionate Care website. Next slide, please. In terms of who you'll be hearing from, Anastasia Dotson from the Deputy Director of the California Department of Healthcare Services, our champion for palliative care through the years. Dr. Mercy Kagoda, hi Mercy, from Inland Empire Health Plan will be talking about their experiences. They're a very, very high functioning plan in terms of their palliative care program, I'm sure in other areas as well. So really looking forward to that. And then myself, Kathleen Kerr, I'm a partner with the firm Transforming Care Partners, and my colleague Lauren Poger, also from Transforming Care Partners, is in the chat with you today. Next slide, please. So before I hand it off to Anastasia to talk through sort of a formal definition of palliative care and the specifics of the policy, we thought it'd be useful to look at to view just a brief video that describes palliative care from the perspective of a member. So what is it? How do members react when they're offered palliative care and when they receive it? What does it feel like to them? Kita, let's go ahead and launch that video.
I am 63 years old. I was born in New York. I have lived most of my life here in California. I have 3 beautiful kids, 5 grandchildren. Got 10 great-grandchildren. Karen is my sister of the heart. She's been in my life for 42 years. When the doctor came into the room, I said, okay, this is serious. He turned around and he said it was pancreatic cancer, stage 4. I think I went into a shock. How do you deal with this diagnosis? How do you deal with your family? They talked about palliative care, and I had never heard of that. I said, what? What kind of care? If you need help in the house, if you're hurting, you need a nurse right away. I went, oh, that's cool.
I was introduced to Louisa as a referral. We have a palliative care team that includes our medical director, nurse practitioner, the nurse navigator, social worker, and community health worker. We spend time looking at the whole patient and really focus in on more than just the physical symptoms. That's really difficult to do in a doctor's office.
Palliative care helps you find a way to deal with this information. It prepares you. It prepares you to prepare others for what you have to do. Because the sooner you prepare your family, your friends, your doctors for what you want, the sooner you can get back to life. Some days I'm good. Other days I can't walk across the room. Whenever you have a chronic illness, you realize what you're limited to. You need help with transportation, cooking, cleaning, walking outside. Palliative care helps me communicate with people because they give me the opportunity to say things that I didn't know how to say. They teach you that it's okay to need. I'm not useless. I have a voice. I am talking more to my kids and keeping them strong. Kay and I have a cactus garden we're starting. We have succulents and they're all growing. It's life. Life is so wonderful, even when you're sick. I love my life. I love who I am. I'm looking forward to what tomorrow's going to bring.
All right. Thank you, Kita. I always enjoy that video. It's probably the 30th time I've seen it, just to remind myself of why we do this, how valuable these services are. And with that, I'll hand it over to Anastasia to talk through the policy part of this, a little more formal description of what palliative care is and what we're looking to do for members.
Thank you, Kathleen, and welcome everyone. Again, really want to thank the California Healthcare Foundation, the Coalition for Compassionate Care, for partnering with us on this. And so, you know, all of you who are on this webinar, I presume, are in some way, you know, employed by, partnered with a health plan that has a D-SNP contract with California. And your D-SNP members, as you well know, are people who are dually eligible for Medicare and Medi-Cal. And as Kathleen said, we have a policy already around palliative care for Medi-Cal only members that our Medi-Cal plans are administering. But this policy was in the care coordination chapter of our D-SNP policy guide, and we added it in time for you all to include palliative care in your models of care for contract year 2024. And I'll go through the slides in just one sec, but I just want to make sure we're all level set on, again, this policy is required for all D-SNPs. And I know sometimes we make the distinction EAE D-SNPs, non-EAE D-SNPs, irrespective. All D-SNPs that are operating in the state of California and that have a SMAC with DHCS in California, the SMAC refers to the policy guide, and the policy guide says for care coordination, it's a requirement for all D-SNPs to include palliative care as a component in their model of care. And the policy guide has a lot of details, and we'll go through the details here too, but yeah, just want to really do that table setting. The other thing I want to flag is that we have a fact sheet about this. So the policy guide itself has a lot of details, but we also have a fact sheet that we just published yesterday, and I will copy that link here and put it in the chat. The fact sheet does not say anything, different necessarily, but sometimes it's a little easier to read through the fact sheet than the, chapter in a policy guide. I don't know. Depends how you prefer to get your information. So with that, then let's go ahead to the next slide. All right. So the palliative care program, we've just got a snippet from the video, and I am not a clinician, so I'm not going to be the best person to give you all the sort of more clinical definition, but generally palliative care is specialized medical care for people living with a serious illness. It is separate from hospice. We're going to cover that later in the training, but it's not the same as hospice. This type of care is focused on providing relief from the symptoms and stress of illness. And the goal is to improve the quality of life for both patients and families. It's provided by a specially trained team of doctors, nurses, and other specialists. And it's based on the needs of the patient, not the patient's prognosis. It's appropriate any age and any stage in a serious illness. And that, I'm not sure who originated that quote, but I really think that's helpful to keep in mind. Okay, next slide. So again, back to the table setting context. So in our Medi-Cal contract requirements, we do have a requirement for palliative care that all Medi-Cal plans must provide an option for specific beneficiaries. We have a whole set of criteria, but that policy does not apply to dual eligible beneficiaries, and that's because Medicare covers the vast majority, or really pretty much all, of palliative care services for dual eligible beneficiaries. So knowing that, and as we looked at the opportunities we had to improve care and patient satisfaction for people with serious illness, then what we did was we put in the, again, the D-SNP SMAC and the care coordination model of care requirements that all D-SNPs have to have a palliative care program. And we, in talking with, clinicians and others, we determined that we should follow the same general and disease-specific criteria that we used in the Medi-Cal palliative care policy. And those criteria are minimum criteria, and then plans can make their, palliative care referral processes and programs more expansive to fit more diseases. But the criteria that we'll go through in the next couple slides is the minimum criteria that all plans must follow. Next slide. So this is just something from a few years ago, and this was SB 1004 is the name of the legislation that required Medi-Cal plans to provide palliative care. But it's, again, different ways of learning information. One other way to think about what is palliative care, how is that different from hospice? And again, it's any age, any stage of illness. And part of what we're trying to express in that graphic is that palliative care can be done alongside curative care. It's not exclusive, and hospice is more of a exclusive type of care model, but palliative care is part and parcel with curative care, particularly for people who are sort of in the earlier stage of serious illness. So again, we'll go to the next slide. Just, I'm not a clinician, so I think you'll get good, hear good information from the clinicians on this training. But we have an all plan letter that outlines the Medi-Cal palliative care requirements, and it's all plan letter 18020. You do not need to look at that all plan letter. It's just for reference. And I know some of you, D-SNPs, you do not have Medi-Cal managed care plans. So, want to acknowledge that as well. But again, palliative care is not something that is kind of exclusively in Medi-Cal plans. Commercial plans, other many hospitals, many health systems already have palliative care as part of their delivery model. So it's not exclusive to Medi-Cal by any means. But this is just the reference on the Medi-Cal side. Next slide. So these are the eligible conditions around SB 1004 palliative care. And again, these are mirrored in the D-SNP requirements. So for SB 1004 Medi-Cal, there's general criteria and then disease-specific criteria for these 4 conditions. And again, the disease-specific criteria is as more clinical language. This is just kind of general language. And then again, the Medi-Cal plans can authorize palliative care for patients with other conditions. These are just the minimum. Next slide. Again, these are the general eligibility criteria. And we worked very closely with a work group of clinicians to develop these general eligibility criteria. And we won't go through each one, but basically, it's meant to look at folks who have are likely to or have started to use a hospital or emergency department as a means to manage their late stage disease. They're in the late stage of illness. Again, we back to that other slide, we had a couple slides back where it was showing any age, any stage, there's sort of early palliative care. In designing our policy, we had to kind of put more specific criteria, but I will say there's many practitioners who will, say palliative care does not need to be necessarily late stage of illness, but because we are, the state, we have to, have things very carefully defined. We put the minimum criteria as being in the late stage of illness, and there's disease-specific requirements. Another criteria we put was the patient's death within a year would not be, and there's an error there, it should be unexpected based on clinical status. So as we think about, physicians treating their patients and how do we kind of fit that into, some clinical guidelines. This is what we came up with. There's, again, more ways to design a palliative care program, but these are intended to be the minimum. And there has been general consensus among the clinicians that have worked on this for the Medi-Cal palliative care program that these are doable. They can be used in different settings and with sort of a broad population, and they fit in with what we'll see, I think, on the next slide around the disease-specific criteria. So for D-SNPs, then policy guide requirements are, frankly, we just moved the same language over. So the patient is likely to or started to use the hospital emergency department to manage their late stage disease. Late stage of illness, not eligible for or declines hospice. Their death within a year would not be unexpected based on the clinical status, and they have received appropriate patient-desired medical therapy or for whom treatment is no longer effective. And again, we've been talking about this is, based on consensus with many clinicians, developed a few years ago and seems to be working well in the Medi-Cal field. Next slide. And then these are additional requirements. They're all in our care coordination section of the D-SNP policy guide. And again, we are requiring for 2024 that all D-SNPs incorporate palliative care into their model of care. So willing to participate in advanced care planning, willing to attempt in-home residential-based or outpatient disease management. And then there are disease-specific criteria for each of those 4 serious illnesses that we had on the couple slides back. And we have all of that detail in the policy guide. Next slide. And these are the services that we're putting together as sort of the model for palliative care: advanced care planning, palliative care assessment consultation, a plan of care, care team, care coordination, pain and symptom management, mental health, and medical social services. Again, there are existing palliative care programs that already incorporate this, plus more or plus something different. We have, again, put these out as the minimum standards for required services, and again, have not heard any concerns about the bundle of services. We'll go to the next slide. And again, provider qualifications. So when we look at again, back to the model of care requirements and the care coordination piece of the policy guide, we're requiring D-SNPs to have an adequate Medicare network of palliative care providers to meet the needs of their members. There's a wide range of providers that you all can contract with, ranging from, hospitals, health systems, clinics, long-term care facilities, home health agencies, hospice agencies, many partners that you can have. And probably you would contract with multiple partners. Again, this series is going to talk about more and help you more in how to get that network. Next slide. So I know there's some questions in the chat. The other thing I will say is what we have heard, and I think we'll talk about this more either in this webinar or others, is from Medi-Cal plans and other plans that have both Medicare and Medi-Cal lines of business, is that really a big piece of the challenge is not necessarily in establishing the protocols and the policies or even contracting with providers, but it is the referrals. And then so the making sure that patients and primary care or specialists understand what is palliative care. It's not the same as hospice. It's not just alleviating suffering, pain without a care plan and a care team type of thing. But the care team, the care plan, interdisciplinary is all part of helping people and their families, process through and, alleviate the suffering on a more sort of global scale for that patient and their family. making sure getting that message of what is palliative care has been, I think, one of the most challenging pieces. So again, we have other presenters to talk about that, but I want to emphasize that all of this should be doable for you all. We would not put something in the requirements that was like, so aspirational without kind of a, bigger on-ramp if we needed that. But we do have technical resources because we know it's not something that you necessarily already have in your models of care. So we want to acknowledge that it is, a change, a shift, an additional requirement, but we have the tools here and with this webinar series to help you get there. Thank you.
Anastasia, just a couple questions. The first one is, there's a requirement that we will identify the type of palliative care the member is receiving. And the question is that in the reference to the chronic conditions, or does it show up somewhere else?
It sounds like that may be in the policy. I'm not quite sure where that question is referencing, but
okay, we'll keep that, and we'll keep that and ask at some point today or sometime afterwards.
Okay.
And then we have another question, which is, will California or CMS provide a network adequacy report or define the number of palliative care providers needed by county, or will be able to determine adequacy?
We are allowing flexibility for the plans, but in the future, we may set a more specific type of network adequacy criteria, but and CMS is not. So this is the state in its, we have authority to put state specific criteria even around services that are Medicare services. So this is, but CMS will not be in their network adequacy reviews for D-SNPs. They do not review palliative care network providers necessarily. So we will, in future years, this is, kind of a phased approach, consider, do we need to have some more specifics about the palliative care network adequacy? But at this time, we do not have any more specific criteria.
Thanks, Anastasia. Just one more question from the chat. It was a question around whether or not it is okay to provide any home-based model, or is it home-based, or is any type of palliative care okay?
It depends on the needs of the patient.
Okay.
So, and I think I would welcome, further thoughts from others as in this webinar, but we don't want to necessarily, I think I'm not the best person to address that, but really it's based on the needs of the patient.
So Anastasia, maybe one way to say it is that you need to be able to provide home-based palliative care for patients who need that. Is that a fair interpretation?
Right. Or yes, patients who need that, if that's the agreement with their provider, with their care team, et cetera. And I, again, my non-clinician, but my understanding is that, people's needs change too. So
yeah. I'm going to jump in. And thank you, Anastasia. I think that the policy stuff, it's written down, but just hearing it is so useful. I'm going to, one more question from Brittany Tucker, just clarifying that there's no difference in the minimum requirements for Medi-Cal versus the D-SNP plans. Is that correct?
That's correct.
Okay, good. Thank you. All right. Well, let's, is it okay to good. Okay. Next slide, please. So, as has been emphasized, there are the requirements for the D-SNP plans and the requirements for the Medi-Cal managed care plans are virtually identical. And so in the hope of making it easier for you to benefit from the lessons learned by those plans, I wanted to share a little information with you from an annual survey that the Coalition and the California Healthcare Foundation have been doing since the program became operational in 2018. The 2023 survey, we had a response from 58% of the plans, and it highlights a little bit how the plans have operationalized and expanded on those minimum requirements that Anastasia described. So there's a link to the full survey results within the slides, and you can look at those later, but let me just go through a couple of the key points. Next slide, please. So first of all, this concept of expanding on the population that's eligible for palliative care, as Anastasia mentioned, there's those 4 required diseases and some general eligibility criteria. What we've seen in Medi-Cal, and then looking at 5 years out from the time of implementation, more than 70% of the plans have expanded on the population that is eligible to receive palliative care, either by specifically adding additional diseases, by relaxing some of the requirements that are applied to the 4 required diseases, or by doing both. So if you are looking to do that, you will be aligned with the majority of the Medi-Cal managed care plans. Next slide, please. In terms of the additional diseases that folks have added, renal disease is the one that's been most commonly added, with 57% of the plans adding that to the specific diseases that are included in the eligibility criteria. Half of the plans have added CVA, stroke, or neurodegenerative diseases. A little more than a third have added dementia and AIDS. So if any of these you feel like, and some of them will be even more prevalent in your D-SNP population than they are in straight Medi-Cal, these are the ones that the plans have most commonly added. Next slide, please. In terms of the required services, Anastasia showed that list of the required services: advanced care planning support, a care plan, an interdisciplinary team, et cetera. A few additional services have been very commonly added to that list. One, and even though the bar is really small there on your screen, it's actually reflecting 77%. 77% of the Medi-Cal managed care plans have added a requirement that palliative care providers offer meaningful access 24/7 for patients who have symptom or other needs. Another 2, which have both been added by 85% of the plans, is that the palliative care providers have the ability to offer home visits during the evening and weekend hours. So if they get that call on the 24/7 line, they need to be able to respond certainly by telephone, but also if it's needed to go out to the patient's home to attend to an emergent issue. And also 85% have added spiritual support. For those of you who are familiar with palliative care, you know that spiritual support is a key domain of palliative care, called for in national guidelines, and so it's not surprising that that was added as a required service. Next slide, please. A number of plans have also, and this is a little bit more of a recent change, begun adding requirements related to providing support to the caregivers of the seriously ill members. And there's still quite a bit of variation here, but things that you might consider as you're defining required services for the providers that you contract with. 50% of the plans require the palliative care providers to offer assistance to members in filling out an application to request IEHS support or to become an IEHS provider, identification of the primary caregiver in the medical record, referral to community or national resources for caregivers, and then short-term counseling or emotional support for caregivers provided by the palliative care organization. So those are some things to consider as you're defining the scope of services that you expect your contracted providers to deliver. Next slide, please. In terms of contracting specifics, what we've seen in Medi-Cal is that on average, each of the MCPs is contracted with a median of 5 palliative care provider organizations with a range of 1 to 16, and that just has to do with the size of the population and the geographic distribution of the members. So it's very common to be contracted with more than one. And even now, 5 years out, good 20% of the plans added a new provider last year to accommodate growing volume. And finally, 38% of the plans require the palliative care providers to be accredited or certified in palliative care by either the Joint Commission or CHAP, the Community Health Accreditation Partner. So that's a certification for the organization that they have the structures and processes in place to deliver good palliative care. Next slide, please. So on top of that, or maybe perhaps in some instances, instead of that certification of the organization that they're all set up to deliver good palliative care, other plans also have requirements related to the training and competencies of the individual team members. And this is most commonly seen for the medical director of the palliative care organization. 57% of plans look for specific qualifications for those folks. A smaller proportion requires certification for nurses or social workers or chaplains. There's palliative care certifications available for all of those disciplines. But a very small number get very specific and say, these are the standards for training team members that we want to see. 38% have no requirements at all. So you can kind of go either way and still be fairly normal in terms of having requirements or not. I, of course, being a palliative care advocate, I really think it's important to have those certification requirements, at least for the medical director. Next slide, please. In terms of who these organizations are, about 87% of them are independent, meaning that they're not affiliated with a health system. And more than half of them deliver care in more than one county, meaning that quite a few of them are small local organizations that operate in a specific area. It's fairly uncommon to say we want one vendor who's able to deliver care across the state. So very common to engage with local organizations. Next slide, please. Finally, two more points. One is that it's most common in terms of the organizations that have been contracted to deliver palliative care to the Medi-Cal population. It's most common for those organizations to also offer hospice. So they offer hospice and home-based palliative care. Many others also offer home health. Many are ECM providers, enhanced care management providers. The point is that these groups typically offer a number of home-based services. Next slide, please. And then finally, most of them also serve individuals with many types of insurance coverage. So not just contract with Medi-Cal managed care plans to deliver palliative care, but also very commonly offering services already to dually eligible individuals, to folks with commercial insurance, and et cetera. So if you approach one of these providers to perhaps cover the palliative care needs of your members, in most cases, it won't be unfamiliar to them to be working with a non-Medi-Cal only population. So the entirety of the responses to both the palliative care provider and the plan surveys that were administered in 2021, those results, a link to them are included on the resource pages of these slides. I'll ask if there's any quick questions about this, but I really want to get to Dr. Kagoda to talk about her specific experiences with operating a palliative care program for Inland Empire Health Plan. Lauren, any questions?
Yes, Kathleen, we just have one question. So
Sure.
on page 15 of the D-SNP policy guide, it states that D-SNPs must have a process to determine the type of palliative care that is medically necessary or reasonable for eligible members. And the question is, what is meant by the type of palliative care that is medically necessary?
Okay, that's an Anastasia question.
You know what? I think we will get to that, I'm sure, through the training. So why don't we just keep going so we can, yeah, thanks.
Okay, great. Well, we will note that and respond in writing or in the next webinar about that question. So with that, Mercy, hello, there you are, Dr. Kagoda. Let's, next slide, please. Inland Empire Health Plan, I've been grateful for their generosity and transparency in talking about their program through the years as the Medi-Cal managed care plans have engaged in peer-to-peer learning and support to try to operationalize the policy. And now, Dr. Kagoda, if you wouldn't mind sharing some specifics about your approach to population and services and your contracted palliative care providers.
Great. Thank you very much, Kathleen. And thank you, Anastasia, for presenting earlier as well. So good morning, everyone. And I'm from the Inland Empire Health Plan, and I'm one of the medical directors, and I oversee palliative care. So there's a huge team of phenomenal people that I work with. So while I'm the only person here, imagine about 1,000 people who are supporting me in this work. So next slide, please. So the counties covered for IEHP include San Bernardino County and Riverside County. These counties are east of Los Angeles, for those of you who aren't in Southern California. We have about 1.6 million lives and approximately 33,000 are D-SNP. The members that are enrolled in MyPath every year are little over 1,000, and we renew the MyPath eligibility every year. Our MyPath provider qualifications, as Kathleen mentioned, there's a huge range, but we recommend community-based palliative care certification, continuing palliative care education, and in addition to our own credentialing requirements. We're currently contracted with 4 adult palliative care groups and 1 pediatric palliative care group. I think the big thing here is that this is a team-based approach. This could not be done by a single person. And so we strongly recommend and we require that this is a team-based approach. So our goals include to improve the quality of life and really decrease the suffering of not only our members, but also their caregivers. Like was shown in the video before, the family is really impacted when there's an illness, and this could be chosen family or blood family. And so we have a responsibility to making sure that we decrease the suffering too for the family members. We require goal setting by the multidisciplinary team that is member and caregiver focused again. We decrease unwanted or futile medical interventions. Next slide, please. So for our MyPath program, we'll go through the eligibility criteria, but Anastasia already went through that. We have expanded our eligibility criteria. So I'll go through that. And then we'll also talk about our workflow and how we handle how people come in, what happens when they come in, what paths do we funnel them into, what happens if they don't quite meet criteria. So for the MyPath eligibility criteria, they must be Medi-Cal or non-delegated Medicare member. So that means that they must have Medi-Cal with us, because sometimes you have members who have Medicare with us, but not Medi-Cal. And of course, that's going to change in the future with the requirements coming down. An advanced medical illness with prognosis of 2 years or less. Anastasia had mentioned the 1 year, we expanded this to 2 years, where, just give people a bit more time. We're open to in-home, the members need to be open to in-home resources for advanced care planning and assistance with symptom management if they're going for the home-based palliative care. So we have outpatient-based palliative care, we have hospital-based palliative care, but this is specifically for the home-based palliative care. Members need to be at risk for using the emergency room to manage their illness, and they have to have declined or not eligible for hospice. Now, this is only for adults. For our pediatric members, we allow them to be on both hospice and also have palliative care. So how do we find the members who may be eligible for MyPath for home-based palliative care? So there are 4 main ways. One is the member may request this. The second way is that the physician, either the specialist or primary care, may request this. The internal care management team, our internal team, as they assist with some care coordination, may find that this member would benefit from palliative care, so they would make a referral. And then we also have an outreach list. This is based off of an algorithm that we came up with that looks at the disease criteria, use of emergency room, hospital admissions. We go through some sort of risk assessment in order to determine members who may be eligible. And then we provide this list to our palliative care providers. So once we have decided people who may be eligible, the next step is a consultation to make sure that they are eligible and or may benefit from this, even if they don't meet criteria. So we ask for a palliative care assessment from one of our provider groups, and this is a separate payment. We don't consider the member to be in palliative care at that point. They're just being assessed. And so at that assessment, the clinician, either the MD or NP, goes into the home and determines whether or not they meet certain criteria. So we require them to fill out a certification of advanced disease. And this is something that we have openly on our website. If you go to IEHP.org and go into providers, special programs, and then go all the way to the end to MyPath, you can get to that. And I'm happy to share this if anybody needs this later on. So we asked them to complete a certification of advanced disease. It has the general criteria, and the key is that it tells us whether or not they would benefit to be in the low acuity or high acuity. So for the low acuity, they meet the general criteria, and the high acuity, they meet the general criteria plus high acuity risk factors. Now, once that consultation is completed, 3 things could happen. One is that they meet criteria and they're either put in low acuity or high acuity. The second thing that could happen is that they don't meet criteria, and that then we look at what other programs or what other resources could we provide for this member. Maybe they need intensive care management for a month or so. Maybe they need just follow up with food resources or something. And then the third thing is they may not meet criteria, but it is medically necessary. And so if it is medically necessary, we will review that. One of us medical directors reviews for medical necessity. And if we do find that there is medical necessity, we will approve based off of medical necessity. So we always say that the criteria is a guideline. It is not something that we absolutely have to enforce all the time. So medical necessity is really trumps the guideline. And I can go into the details of high versus low acuity, but it's also on our website. You're welcome to look at that. And so in terms of our expanded eligibility, so as Anastasia mentioned, cancer, CHF, COPD, and liver disease were the 4 diseases. We expanded our disease criteria to also include the neurodegenerative disease, dementia, end-stage renal disease, and AIDS. And then we expanded our general criteria to prognosis of 2 years or less and non-compliance issues. So if we go, I think I have, this is my last slide. So if we just step back and think about what would be the biggest thing I'd probably say has made us really successful with providing care to our members. I think the biggest thing is that this is a team-based approach. None of us can do this alone. And having a group of phenomenal people who are passionate about palliative care is necessary to be able to do this work. And this is not only just internally, but also externally. Our four palliative care groups, adult and 1 pediatric, I mean, I don't know what the numbers are for some of those groups, but I saw that the numbers were higher than, there were about 7. We've kept it about small to about 4 because it helps us develop strong relationships with the palliative care groups. They have my cell phone number. They can reach out to me at any time. And then it helps us support them and grow them. We found that after a certain number of members, the palliative care groups are more likely to be successful. And it really makes it easy to control the quality piece. We audit our members once a year, and we are available for support to them. We have interdisciplinary care teams and that are twice a month with them. So it's pretty intensive work that we do. And so if we had 20 palliative care groups, I don't think we'd be able to do that. Okay, so I think that's it from me. So I'll just wait for some questions. Thank you.
Thank you so much. Feel free to enter questions in the chat and we'll field those. I have a couple of questions for you about the service tiers. Do members ever go back and forth between high and low, or is it based on sort of more permanent criteria where that's unlikely to happen?
Okay, so your question is, with the acuity levels, the high and low, do members just stay in one path for the entire time, or do they switch back and forth? So our members do switch back and forth. Someone might come in high acuity and after a year goes to low acuity. So we recertify every year. Or somebody might come in at low acuity, and then in the middle, maybe 6 months into it, there's something changes and they need to be switched to high acuity. We can switch to high acuity.
And do you require different services for low versus high acuity, like the amount of palliative care that's delivered or by whom?
Absolutely. So for high acuity, we do require that there's one licensed nurse visit every week For low acuity, it's every 2 weeks. And for either low or high acuity, we require that either an MD or a nurse goes into the home in addition on an as needed basis. But if I was to say the one thing that differentiates high acuity versus low acuity is the number of visits. So once per week minimum, it could be more. So this is, again, just a guideline. Sometimes they're going in 2 or 3 times a week, but if they're high acuity, at least once a week, a licensed nurse needs to be in the home.
Mm-hmm. And have the palliative care providers, has it been okay with them to have these sorts of frequency requirements? Is it something they struggle with? Is it, what's your experience been?
Yeah, so that's a really good question. So has this been a struggle for them, the requirements we have over low acuity versus high acuity? So I'll say in general, it hasn't been. However, during the pandemic, there was a shortage of staff. People didn't want people into their homes. So there was a struggle there. So whenever there's some sort of struggle or issue with that, they reach out and let us know. And I think that's the biggest thing, is keeping the lines of communication open. The guidelines we have and the requirements we have are there, but we also want to continue talking about this and figuring out how can we support you to make sure this happens. Sometimes there are instances where maybe it's not possible. Let's look into that. Let's talk about it and figure out other ways to make sure that the member is taken care of.
Yeah, thank you. I'm wondering about the you have multiple providers, not just one. Is that largely just because of service geography, or did you want like a range of competencies in the network that you put together?
It actually ended up, we're pretty large with the 2 counties and then with the expanded area. So it's just geographical size. We needed more groups of providers to really provide the services. Yeah.
Is there, I saw that you do you encourage or require certification?
So we require certification, but there's certain things that we encourage in addition. Yeah.
Yeah, say a little more about that.
So we require the Joint Commission certification, but we definitely encourage continuing the palliative care continuing education units. For the social worker, chaplains, for the physicians, it's easy because we have these requirements from the state and our board licensing. But we definitely encourage for the social worker, for the chaplain, for the nurses to continue with their palliative care education.
And then did the providers find that burdensome, or is that what they're doing anyway? Or what has their response been? I know sometimes there can be fears that if you require a lot, you'll have trouble putting together a network. So
in terms of whether this is burdensome or not, I have not heard anything about it being burdensome, because I think we partly went into medicine because of how we're continuously learning. You know, you don't stop learning in medicine. And so we have that learner's mindset. And so I've never heard of anyone saying, I don't want to keep learning because there's something new. So that hasn't come up yet, but we'll see. Yeah.
Excellent. Thank you. And then just one final question about the required services beyond frequencies. Do you have any specific requirements around what the palliative care providers do for the member caregiver?
So we don't have any requirements for what the palliative care providers do for the member caregiver, because we have an amazing internal team that helps with helping with, for example, IHSS hours, if they're eligible, and then they can be referred to places for caregiver resources. So we already have an amazing internal team. We try and make sure that our palliative care providers utilize our internal resources. And that's why we have those interdisciplinary care rounds very frequently, because we're like, hey, we have these resources internally that you may not be aware of, and we don't need you to duplicate them because we already do such a good job with them internally.
What a terrific closing point of don't let your palliative care be siloed, that you have a lot of services, a lot of resources within the plan, integrate palliative care, avoid duplication, and get the most that you can to your members. Dr. Kagoda, thank you so much. That was so useful to hear from somebody who's lived this and overseen it for many years now. Keita, we can go. And so thank you very much.
Thank you.
We'll go back to the slides now.
Oh, Kathleen, we just have one quick question, if you don't mind. Sure. So there's a question about your outreach process. And the question is, once you actually have the outreach list, do you call the patients or do you ask the palliative care providers to reach out to the patients or to the members?
Yeah, so that's a really good question. So once we have the outreach list, what happens next? So there are two different options. So one, the most common one is that we provide this list to our palliative care groups. And we say, these are the members we have found that may be eligible. Please reach out to them and see if they're willing to do a palliative care assessment. And then once your assessment finds that they could benefit from the services and they're interested in the services, please get them onto palliative care. The other option is that for some groups will call together and do the, do the call, kind of do a warm transfer so that the member and the team meet at the same time. Because one of the issues with just calling a member without the member knowing who you are, it's like, why are you calling me? And so some teams are not as comfortable with reaching out. So those are the two options. Does that help answer your question?
That's great. Thank you.
Thank you. Yes, it does.
That's terrific. I thank you again, Dr. Kagoda. The entire third webinar is on this really important process, which is how do you identify people? How do you promote appropriate referrals? How do you promote awareness? Because it really is central to success. So just a few closing thoughts in terms of things that we're hoping that you'll consider. Consider reaching out to the Medi-Cal Managed Care Plan Palliative Care Program folks to ask about their experiences. And it could be something really specific, like, well, who are you contracted with in this area? It could be about key processes, et cetera. They've been living this for 5 years, and many of them have really valuable lessons to share. Also, as we described as I described in the survey results, consider expanding access by relaxing some of the or modifying some of the general or disease-specific eligibility criteria, and also by thinking about additional diseases that you think are prevalent or that you know to be or you expect to be prevalent in your D-SNP population. And finally, think about expanding services. In particular, 24/7 access and spiritual support are very commonly required, really key to successful palliative care that's emphasized by palliative care professional societies. Next slide, please. In terms of some resources, these are actually links that are embedded in the slides. We'll also reproduce them in the little 2-page handout that we're creating. The first link is to the palliative care policy guidance page that DHCS has. It has information about both Medi-Cal palliative care and D-SNP palliative care policy. There's also a link on that page to the fact sheet that Anastasia referenced earlier. Also, the CHCF, California Healthcare Foundation, Essential Elements of Medi-Cal Palliative Care is a wonderful resource that puts together a lot of the lessons learned by the Medi-Cal managed care plans over the years as they've implemented their palliative care programs. There's both a web-based version where you can navigate around and look for what you're interested in. There's also a single PDF that you can download. A lot of good information there. There's a link to the full results of the 2023 Medi-Cal Palliative Care Plan and Provider Surveys if you're wondering more about what the collective experience has been. And then finally, there's a link to the documents that Dr. Kagoda referenced, their policies, their member outreach materials, their certification of advanced disease form, et cetera. All of that is available on the web. And then just as a reminder, the slides, a brief summary of the key points from today, and a link to the webinar recording will be distributed to all. So in case you want to access this information later or share it with peers. Next slide, please. We're just about at the top of the hour, so we'll won't have time for any more questions, but just to let you know, if you have a question that we didn't have a chance to get to, just email it to my colleague Lauren at transformingcarepartners.com. We'll respond to you directly. If it's appropriate, then we'll include the question and the response in the little write-up. Really eager to make sure that this is tailored to your questions and needs, or we'll include a response in the next webinar. Next slide, please. And then finally, just a reminder about the next webinar that'll be in August. We're going to focus on program administration, payment model, and quality monitoring. And again, really emphasizing the experiences of those who've developed programs for Medi-Cal or for other D-SNP populations. So with that, Jennifer, any closing words before we sign off and thank these folks for joining us?
And actually, this is Chris. Jennifer had to drop off, but
Great,
just
Chris.
Excited about the amount of people who registered and the amount of people who participated, and looking forward to the next webinar.
Great. Thank you all. Thanks for coming. See you next time.